Good morning and good afternoon, everyone, either from Europe or from China. This is the very first symposium we're doing for when East meets West. We believe at the European Psychiatric Association that mixing, exchanging, learning from others is our motto. So it is always a benefit to have these kind of exchanges. So I really would like to thank Professor Yun Chen, my friend, coming from Shanghai University in China, with whom we will share this session. As we have a dance program, 4 presentations, all of them about the treatment of depression at its best, and what is our habits, what are our techniques in our 2 continents. We begin by Koen de Mittenaar, who's Professor of Psychiatry in Leuven, Belgium. So please, Koen, you are welcome. Thank you.
Thank you very much for the kind introduction. Hello, everybody. You're probably at lunch. We are at breakfast. That's the only difference, I guess. So my short presentation will be on the Western concepts of treatment-resistant depression and difficult-to-treat depression. My disclosures. The question is, do we need something like the word or the concept of treatment-resistant depression? Is there a clinical need? Because does it make a difference if a patient doesn't respond to 1 treatment or to 2 treatments or to 4 treatments? That's the first question. The second one is, why would we do that? Maybe it's for the regulatory bodies who are looking for more homogeneous patient groups. Or maybe it's budget limitations imposed by payers for new first-line treatments. Or it's access limitation for more invasive treatments or more expensive treatments like esketamine or VNS, for example. The concept of treatment-resistant depression, you see it quite a lot in the literature. And don't forget that there's about 115 different published definitions. And they all hesitate a little bit between a categorical approach, or you have treatment-resistant depression or not, or a more dimensional approach, which is then often called staging, where you are more or less treatment resistant. And most of these definitions take into account the number of treatment failures. Half of them say at least 2 different treatments for a sufficient duration. And some of them go further and they try to differentiate better. For example, they give a different weight, for example, to a tricyclic than to an SSRI. So is it so that some antidepressants might be more efficacious than others? What weight, if you make a staging, what weight do you give, for example, a combination treatment or an augmentation treatment? And then they take into account the duration of the episode and the severity of the symptoms sometimes. That's more the staging models. What is not sufficiently taken into account is the psychosocial factors influencing outcome. I'm going to give you an example of that. Psychotherapy is usually not in it. And neuromodulation has also a very small place. Only 11% of all these definitions have something on neuromodulation, and then it's mainly ECT or RTMS. The terminology is another problem. One speaks about treatment-refractory depression, treatment-resistant depression, absolute resistance, relative resistance, chronic depression, recurrent depression, relapsing depression. And even in Time Health magazine, it was called stubborn depression. And that's a very difficult term. Stubborn depression, because refractory and resistant are close to stubborn. Because who's stubborn? Is it the depression who is stubborn, or is it the patient with the depression that is stubborn? And maybe therefore it would be better, because that term stubborn depression and even refractory or resistant is devoid of any empathy. And maybe that's better that we move towards the concept of difficult to treat depression. When you look at the different words, treatment-resistant, refractory, or difficult to treat, is a complete different meaning of the words, because resistant comes from the word resistere, that's oppose, make a stand against, stand firm. It's almost like blaming the disorder or the patient. Refractory depression, refractarius, is stubborn, obstinate, same story, blaming the disorder or the patient. While difficult to treat depression, treat comes from tractare in Latin and means dealing with, handling, negotiating, managing the depression. It's much more a collaborative concept where the patient, the family, and the physician can collaborate. And it's also closer to what depression in reality is, a chronic illness model. You all know that once you have a depression, you're probably going to have a second one. And if you have 4, you're sure you're going to have 5 episodes of depression. While treatment-resistant and refractory depression are more the acute illness models. Another advantage of the term difficult to treat depression is that it's more biopsychosocial. So I said difficult to treat depression. The concept is much more biopsychosocial. It's closer to the capability approach. What can you do despite maybe residual symptoms that we cannot all cure? It's also closer to what is called the recovery moment, optimizing symptom control, minimizing the impact of symptoms on living conditions. Difficult to treat is also more dimensional. It's about the waxing and waning course of depression and its depressive symptoms. So, because it's much more difficult to treat, is also closer to getting the patient well and also keeping the patient well. This is from STAR-D, because you all know that the more treatments you need before a patient gets into remission, well, the more there is a risk of relapse or recurrence. And that is what you see here elegantly from the STAR-D study. If you needed 4 treatments before you got in remission, then your time to relapse is much shorter. So it's not only to get the patient well, it's also to try to keep the patient well. But before talking about that, I think we have to have some idea of what is now the efficacy of our treatments. And in fact, it's 3 different aspects. There is first the natural course. And, regression to the mean, it's in fact normal that you can expect that there will be an improvement spontaneously. Second, there is what is called sometimes placebo effect. In psychotherapy, it's more called the non-specific factors. And on top of that, you have the pharmacological action of the chosen antidepressant. So that's the different aspects of treatment outcome. Because let's look first at untreated major depression. This is a study, untreated major depression. Well, what do you see? After 3 months, 23% have a spontaneous remission, 32% after 6 months, and 53% after 12 months. But the figures were lower in severe depression. Does that mean that we do not have to treat our patients? No. If we can increase these figures, or if the duration to remission is shorter, that's of course a huge advantage. So therefore we should treat them. This is here now the long-term outcome of treated major depression, psychiatric in and out patients. And why do I show the slide? Well, it's just to say never give up. Never give up with your patient who is chronically depressed, who is difficult to treat, who suffers from difficult to treat depression. Because here you see that only 11% do not recover within 5 years of follow-up. And even from those after 5 years, still 7% of those will recover in the next 5 years. So that means that in fact, after 10 years, 93% of the patients will remit. Don't forget that. Never give up. I said psychosocial factors are not taken into account, and that's a huge problem. This is again taken from STAR-D, and overall it was a little bit disappointing. You all remember the first step in STAR-D was 12 weeks of treatment with citalopram, and overall it was only close to 40% of remission or responders that you had. And however, and a subsequent analysis by Senior et al., what do you see? You take into account some some psychosocial factors and some biological factors, clinical factors, and then it changes completely. You take into account education, being employed or unemployed, and gender, and you look, for example, is it anxious depression or non-anxious depression? Then all of a sudden, just by taking these few factors into account, it's no longer about 40% of response, but it's in between 31 and 63%. So before we move to personalized medicine, we should first take the person into account and not only the biology. This is, again, to say, what can you expect once somebody fulfills the criteria for so-called treatment-resistant depression to subsequent treatments for a sufficient duration without a good response? Well, this is taken from Fekado here. Well, you see, again, never give up, because 50% of them will within 3 years be completely in recovery. About 15% of them will have been somewhere in remission, but not permanently. And some 20% will be in a subsyndromal state. And indeed, some 20% will, after 3 years, still be suffering from depression. Before you fight with treatment-resistant depression, you have to consider a few issues. Was the diagnosis right? Did we miss the psychiatric or somatic comorbidities? Because those patients are more difficult to treat. Were the psychosocial aspects, was psychotherapy adequately considered? Was the antidepressant dose sufficient and the treatment duration adequate? And never forget, was the compliance to the treatment there? Because that's maybe a very important one, as I'm going to show on my last slide. Were there adequate drug plasma levels for those where we can achieve them? Or was the treatment response maybe masked by adverse event of antidepressants? For example, you can have a patient who still has lassitude, but what's the difference between lassitude due to the depression and sedation due to some antidepressants? And where the comorbidities take into account. This is my last slide, just saying, don't forget adherence, because look first at the right part of the slide. Well, there you see that 50% of patients stop antidepressants within 2-3 months after treatment initiation, which is not enough, as you all know. That is a graph that you can find in the US, that you can find in Asia, that you can find in Europe. So 50% stop prematurely. And this is often said to be the reason that patients don't like antidepressants, that they prefer psychotherapy. But look at the left part of the slide. This is the treatment duration for psychotherapy. And this is from the NHS in the UK. Patients coming in for psychotherapy, and what you see there, that 74% of them have less than 6 sessions in total. You see that even 28% stop after 1 session. So it's not a matter of being a little bit afraid of antidepressants, it's also being afraid of psychotherapy. Don't forget that there's always some ambivalence in our patients. And that's my very last slide. I think because treatment resistance is about fighting, but I think, and I'm quoting Dun Tzu, supreme excellence consists of breaking an enemy's resistance without fighting. And that's why I put a slide from capoeira, which is a kind of ballet dance in Latin America. Thank you for your attention.
Thank you, Professor Demetri. Your great presentation and host the first topic of the combined therapy for depression. So hi everyone, I'm Dr. Jun Chen from Shanghai Mental Health Center, currently working in the Clinical Research Center. So for me, I'm very happy to host this symposium with Professor Philip Gowood. When 2 years ago, we talking about enhance the European and China cooperations. And finally, today we have the first When East Meets West symposium. So when we're talking about the treatment of depression, always thinking about combined therapy. I think the current situation in China is the same in Europe. So next, I'm very glad to invite my friends, Dr. Shaohua Hu. He's from the Psychiatry Department of First Affiliated Hospital in Zhejiang University School of Medicine. Shaohua is a very young psychiatrist in China, and he had a lot of editorial board member experience. The most important one is he is the young editor board for the Lancet Psychiatry. So next time is for Shaohua. Your turn.
Then you have to stop sharing your screen first.
Thank you, Dr. Chen. Hello everyone. I'm Shaohua from Zhejiang University. Today is my pleasure to communicate with foreign colleges. Firstly, I share my slides. My topic is add-on treatment for Chinese patients with depression, the divergence between guidelines and the clinical practice. Kong has given us the new concepts about TRD. So we can see.
Could you full screen
okay.
your slides?
Yeah.
Okay.
Yeah, it's my disclosure. In my lecture, I will tell the prevalence of depression, now the challenges of pharmacotherapy, and the Western and Eastern guidelines for add-on treatment for TRD. And I will share our experience about the management for TRD patients. And we also discuss some data from our team, the newest research. Sorry. Yeah, we can see some newest the prevalence data around the world. In China, we can see the life prevalence is about 3%, but actually the prevalence data was underestimated. We can see in the other development countries, USA and Switzerland, is a higher prevalence than China. And The major depressive disorder has given a very heavy burden of social and economic for the population. We can see that over 40 million people suffering from MDD in China. It's a cross-sectional, nationwide survey from 2013 to 2050, including 32,000 participants. The data was published in the Lancet Psychiatry. I should hide the, sorry. The challenge of the pharmacotherapy for the TRD, we can see we are facing such a phenomenon. Lower treatment response rate. About 60% of the patients not achieving adequate response following sufficient treatment of antidepressants. And we also facing the delayed response to treatment. Almost the TRD patients should take several weeks for common antidepressants to work. In the past decades, the cognitive dysfunction arised our physicians' attention. Now we think cognitive function is an independent risk for relapse and for his social functioning. So we can see significant moderate cognitive deficits in executive function, memory, working memory, and attention was impaired in many TRD patients. We also see many TRD patients impaired in their social function. Let's see the newest guideline from CMED to from the CMED guidelines. We can see facing TRD, we have some recommendation for adjunctive medication, such as 2nd-generation antipsychotics. Aripiprazole, quetiapine, and risperidone was recommended for level 1. And the second line, we can use some lithium or olanzapine. Third line, we can see other antidepressants or TCA. And we also can use the faster acting the antidepressants such as ketamine. And in the CMED guidelines, physical and meditative treatment was recommended for the TRD, such as exercise, light therapy, yoga, acupuncture, and sleep deprivation. Natural health products was also recommended, such as omega-3 and DHA and some tryptophan. In the past decades, non-surgical brain stimulation has mounting evidence for the TRD. In the practice, navigated RTMS is the first line for TRD. And the MECT is the second line. TDCS is the third line. VNS, DBS, and MST has more and more evidence for TRD. In many TRD patients, we know they have some psychological factors. So psychological treatment has some evidence for the patients. We can see this meta-analysis paper. The efficacy of add-on psychotherapy plus TAU is better for only TAU. TAU means treat as usual. Now I will I will introduce our Chinese guideline for MDD prevention and treatment, the second edition, published in the 2015. In Chinese guideline, for the TRD patients, we can recommend the high dosage drug therapy, and we can change the primary antidepressant drug to another of the same class or of a different class. We also can combine of pharmacotherapy, combine the pharmacotherapy and the psychotherapy, and combine the pharmacotherapy and the non-surgical brain stimulation. In a survey study, we can see in the past 2 decades, Chinese patients are treated many type of antidepressants. SSI and SNI is the major medication for the Chinese patients. We can see SSI, the amounts increased in the past 2 decades. And in the practice, long-term benzodiazepine was used in patients with MDD in China. In this study, we can see long-term benzodiazepine user is about 36% in the MDD patients in China. So it's a serious problem. We know that long-term benzodiazepine will give the cognitive impairments and other severe problems. In a real-world study, we can see the real management of treatment-resistant depression in China. We can see monotherapy is just about to 28%, and the polytherapy means antidepressants and antipsychotics about 30%. 2 antidepressants is a severe problem, I think. It will induce the serotonin seizure about 22%. Antidepressants and anticonsultants about 4%, and other combination. And we also can see the adjunctive treatment to antidepressants in TRD. In China, we can use antipsychotics and use MECT and other antidepressants. So I think existing problem of TRD management in China, first one is the diagnosis problem. We can see about 20 to 30% of TRD are actually bipolar disorder, or the diagnosis is wrong. So I think the clinical diagnosis is the first issue. And the 2 is the clinical management. I think that the assessment, we can use the skills and lab investigator is necessary for assessing the clinical features of MDD patients. And we also pay attention to the side effects of antidepressants, such as sexual dysfunction and cognitive impairments, and even metabolic syndromes. So I think it's another important issue. And in China, we all know psychotherapy is very important, but in the Chinese systemic service system, we can't provide sufficient psychotherapy service for MDD patients, even TRD patients. And in China, we have no sufficient systemic rehabilitation support for TRD patients. So I think in the future, we should strengthen such services system. That's all. Thank you.
Thank you very much, and definitely very interesting to see all these prescription habits in China. Thank you for that. We will go directly then to Hamish. Hamish is our bravest psychiatrist waking up this morning at 5:30. Just so sorry for that for the UK time. He will give an overview of the worldwide treatment options for difficult to treat depression. Hamish was the leading author of this global review, so he's perfect presenter for that. Thank you, Hamish.
Great. Thank you very much indeed, Philip, for your very kind introduction. I'm going to be following on from Dr. Hui with regard to thinking about a framework for using the various different treatments. There are more similarities than differences in the issues between East and West and the treatments that we're actually using. And I'm going to be building upon a concept that Dr. Demittinière presented earlier on. So those are my disclosures. I'm not going to be going into specific treatments to any great extent. What I will be doing is I'll be presenting a framework from the consensus that Professor Gorwood was just mentioning. He was one of the authors, along with Professor Demittinière, published last year in the Journal of Affective Disorders. In that particular consensus, we came up with suggestions for a structure for how we might manage treatment-resistant, or as we were really specifically focusing on, difficult to treat depression. And we came up with 8 steps in our management. And I'm going to just go very quickly through those 8 steps. The first one is very much around optimizing symptom control. And we emphasized many of the things that have already been mentioned this morning, using conventional treatments, conventional antidepressants, psychotherapies such as CBT, when those are available, because there are limitations wherever you are in the world, and also considering the growing number of neurostimulatory treatments. Thinking about what we do if first-line treatments are not effective. We've got various options around antidepressants, 3 major ones, or 3 really, all of them can be summed up in 3. We can increase the dose, we can switch the antidepressant, or we can add in a second medication. We can think about an alteration in the psychotherapy or add psychotherapy to antidepressants if we can. And we can also think about alternative neurostimulatory treatments. In terms of what we use, I think there are variations between different countries. These are some guidelines from the British Association for Psychopharmacology, emphasizing first-line quetiapine, aripiprazole, and lithium. Slightly different to the Canadian ones, but not a million miles away. Second line, a couple of other antipsychotics, risperidone, olanzapine, triiodothyronine, or mirtazapine. Now, in terms of optimizing symptoms, in the paper about managing difficult to treat depression, we emphasized the importance of also considering treatments beyond those straightforward monoaminergic treatments with antidepressants and second-generation antipsychotics particularly. What do we mean by non-conventional treatments? It's really any treatments that are not in guidelines as first or second line options. That might be a bit more expensive, they might be a bit newer, they may be more invasive. In the British guidelines, we talk about some drugs which have got slightly less evidence base around them, bupropion, buspirone, lamotrigine, and tryptophan. And we also talk about medications such as modafinil, estrogen, and testosterone in women and men respectively, where there again is somewhat less evidence. But we can also think about newer treatments, treatments like esketamine, which I think you may be hearing a little bit more about in the next presentation, or more invasive treatments such as vagus nerve stimulation, requiring the surgical implantation of a pacemaker-like device, something that we're not going to be rushing into doing first or second line, or possibly even not third line treatment for patients with depression. But the point is that we need to be thinking about all of these options and introducing them at an appropriate time in our treatment algorithm for patients with difficult to treat depression. In the principles, we then move on to thinking about whether there are some symptoms that we might particularly want to target, such as those associated with poor outcomes, including anxiety and pain, comorbid pain, and symptoms that can really negatively impact on quality of life, such as sleep problems, fatigue, and cognitive problems. We emphasize the importance of managing comorbidity because that is the norm rather than the exception for patients with difficult to treat depression. And those comorbidities can be physical, mental health, substance misuse, or they can be iatrogenic, caused by other treatments that the patient is actually receiving. We need to optimize prophylaxis because we know that the risk of relapse is higher in patients with harder to treat depression. We also emphasize the importance of encouraging self-management. This can help the patient engage with their own management and with healthcare services. And it includes a range of different things, including such things as encouraging good sleep patterns, exercise, good diet, using online resources to actually help, but also very much encouraging skepticism that the view that the person is never going to get better is overly pessimistic, and that there is always room for improvement, as Professor Demitinier emphasized in his presentation. It's important to have clear pathways of care. This is a counsel of perfection, and I suspect that most countries around the world would struggle to follow the specific recommendations that we were making in the paper, but we were keen to emphasize what we felt was the ideal. And the eighth step in many ways is the most crucial of all, and that is regular reviews of patients that are proving difficult to treat, reassessing the severity of their symptoms and the degree of functional impairment, re-reviewing the diagnosis and reconsidering the diagnosis. Could it be that there is some other underlying diagnosis, for example, bipolar disorder, which is making the depression harder to treat? Screening for comorbidities, because as I've said before, these are the norm rather than the exception. And then reviewing all of the etiological factors that are predisposed to the depression, that have precipitated the current episode or are perpetuating the episode going on, and addressing any of those that we might be able to. Thinking about any medications that can be withdrawn because these patients tend to accumulate more and more. Thinking whether there's any medications that could be optimized. Are there any other treatment options that could be considered? Thinking about all different treatment modalities, medication, psychological therapies, neurostimulatory, self-help, and then whether we need to refer the patient on to a specialist service, maybe for a more specialist treatment, such as vagus nerve stimulation. So those are the 8 principles that we put together in the framework for managing difficult to treat depression. We believe that it is important to consider the management in this more complex, structured way, rather than simply thinking about serial acute treatment trials. Key is identifying treatable causes of depression and treatable causes as to why the depression is proving difficult to treat, having a clear strategy, using all of the different treatment modalities available, and considering non-standard treatment strategies in a timely fashion. So I hope you found that of use, and I'd point you once again to the reference on the bottom right-hand corner of the slide, which is the consensus document, which provides more detailed information. Thank you.
Thank you, Professor Williams. It's a very new idea, guidelines for DDT. And I think in China, we're also struggling with the treatment of DDT patients. And we're thinking about new treatments, for example, ketamine add-on treatment for depression patients. So next, I will be very glad to introduce my friends from Guangzhou, Professor Yuping Ning Yuping 教授. Professor Yuping is the Chief Executive Officer of the first affiliated brain hospital, Guangzhou Medical University. And also she is the Vice Chairman for the Management Committee of Psychiatric Hospital of China. By the way, her hospital is the first hospital in China in the psychiatric hospital. So in the last decade, Professor Ning and her group have focused on the ketamine treatment for depression, So this time, she will give us a topic of a ketamine add-on treatment for depression, data from China. So next, Professor Ning.
Hello, Dr. Chen and everybody. Can you hear me?
Yeah.
Okay, it's my honor to participate in this conference. And thank you, Dr. Chen and the organizer for inviting me. I would like to talk about ketamine add-on treatment for depression. Data from China, actually from my group. Okay, next slide, please. This is nothing to disclose. I would like to talk about the following three aspects. Next slide. First of all, let's review a brief history of ketamine. It is first discovered in 1962, and there's abuse reports and FDA approved as an anesthetic. Actually, it is being used as very good as an anesthetic, especially in adolescent and old age people. And in 2000, Berman proved its rapid antidepressant effect for the first time. And next slide, please. Okay. And in 2013, the FDA granted a S-ketamine nasal spray for TRD. And in 2016, for MDD use, it is showed imminent risk for suicide. And 2019, FDA has approved S-ketamine nasal spray taken with an oral antidepressant for TRD. And 2000 for MDD, it's with acute suicidal ideation or behavior. Okay, next slide, please. And next, I would to show you an update systemic review and meta-analysis. In this meta-analysis, there is 28 studies. The result is it shows a strong ketamine effect at 4 hours following a single infusion and peaked at 24 hours. And ketamine's effectiveness was still present even after 7 days of infusion, though somewhat diminished. And it shows that multiple infusion result in an enhanced and prolonged ketamine effect. Next slide, please. And about anti-suicidal effect, there's a systemic review. This systemic review shows the ketamine effects on remission of suicidal ideation. Compared with a control group, the ketamine group showed a greater proportion of patients being free from suicidal ideation at the post-infusion days 1, 2, 3, and 7. And over half of the participants reported no suicidal ideation across all post-infusion time points. Next slide. Next, I would show you our group's data. We have performed studies for 3 years. We include 97 samples, give 6 times altogether, 6 times infusion, last 2 weeks. We shows the average time to response was 10.5 days, and the remission was 14.2 days. And the response rate is 68%. Remission rate is 15.5%. That is to say, among the 19 patients, 31 has non-response, while 66 has response. Next slide, please. And we also studied the effect on suicidal ideation. We can see of the 26 patients with suicidal ideation, 57% have anti-suicidal response after first infusion, and 65.1% response after the sixth infusion, and the 70.6% patients remain in anti-suicidal effects at a 2-week naturalistic follow-up. And the mean time to relieve suicidal ideation was 3 days in low suicidal ideation group, 6 days in high suicidal ideation group. Next slide, please. Next slide. Thank you. And about the safety of adjunctive therapy, we have a group of data. First of all, these associative symptoms, there shows the ketamine was associated with mild but marginally significant increase in these associative symptoms as measured by the CADS during the first infusion. And this associative symptoms was returned to baseline 24 hours after the first infusion. Next slide. As to the cognitive function, there shows the neurocognitive function would not deteriorate after 6 ketamine infusions, while verbal learning and the speed of processing improved over 13 days and 26 days of observation. Next slide. Cardiovascular effects of repeated use. Blood pressure and pulse evaluation following subanesthetic ketamine infusion are transient. Older age, hypertension may predict increased ketamine-induced cardiovascular effects. Next slide. Okay, side effects and adverse reaction of ketamine. Acute or cumulative effects, psychiatric or psychotomimetic. There is anxiety, agitation, or irritability, and euphoria, delusions, or unusual thoughts, and dissociation, etc. And cardiovascular, there is increased blood pressure and increased heart rate and palpitations or arrhythmia or chest pain. And neurologic signs, there is headache, dizziness, sedation or drowsiness. Others include blurred vision and nausea. This is acute effect. As long-term side effects, there is potential urinary tract side effect, potential cognitive side effects, and potential dependency risk. Next slide. The reported side effects are most acute or cumulative. The long-term trajectory and the consequence of potential side effects are largely unknown and needed to be evaluated. Next slide. And we compared the ketamines with oral antidepressant and ETC. Ketamine versus oral antidepressant, it shows more rapid acting and robust effect. While compared with ETC, ketamine no need for anesthesia or hospitalization, and has comparatively lower cost and even faster acting than ECT, and fewer short-term cognitive impairments. Finally, no stigma. Okay, next slide. And what about the adolescent and old adults? There's some studies shows rapid antidepressant or anti-suicidal effects with better outcomes following large repeated doses, and appears to be safe and well tolerated. However, the studies are small quantity and generally low quality. For example, open labeled, or some are case reports and with low contrast. And RCTs are still required to ascertain effectiveness, safety, and tolerability in this group. Next slide. And other use besides depression, what about anxiety and PTSD? There's some small sample size studies shows rapidly reduce core symptoms, severity in patients with chronic PTSD, and shows an interesting mechanistic aspects to investigate is whether ketamine acts via interference with fear memory reconsolidation in PTSD, and also reduced anxiety symptoms in adults with treatment-refractory generalized anxiety disorder. Finally, what about OCD? It shows mixed results were reported in patients with OCD. Next slide. Next slide, please. Okay, summary. Sorry, the formal one, the formal slide. Okay, I would like to talk about summary. The ketamine add-on use shows rapid acting and robust antidepressant and anti-suicidal effects, and is a safe and well-tolerated treatment. It shows long-term safety needed to be evaluated. RCTs are still required just to ascertain effectiveness, safety, and tolerability in adolescent and older adults. And it also shows potential as novel drug for anxiety and trauma-related disorders. The last one. Okay, I would like to thank my group and thank National Key Research and Development Program for China. The last picture is my group.
Great.
Thank you.
Thank you. Thank you very much for a very rich presentation. I know it's a bit of a challenge to do those presentations so shortly, but it's so nice to have all these interactions and different points of view. So really appreciate it. I would like to share with you the point that we have more than 160 participants this morning. Just incredible for us at this time of the day, and so nice to have this interest on both our continents. We have a couple of questions. Maybe I'll take the first one and you'll take to the other one. The first one initially was mentioned for Kern. Are there any new ways to increase adherence with all the antidepressants? As you mentioned, it's a relatively poor. Can we do progress in this regard?
I think the first thing is that we have to be aware that patients have an illness theory, and that what we propose as a treatment fits with their illness theory. So it's not like you have a virus or you have something antiviral or a microbacteria and you have antibiotics. So I think patients, and I think explaining, and I think another thing, explaining why an antidepressant can indirectly solve problem, bring you back in the driver's seat just to tackle your problem. And I think that another thing is that you have to take into account patient preference. There are studies that show that patients who prefer psychotherapy do better with psychotherapy. Patients who prefer patients do better with antidepressants. So taking shared decision making, it is sometimes called. I think these are the two things that we have to take into account.
And beyond the sea, what's about the opinion of our Chinese experts on what can we do to increase the quality of adherence in our patients with depression? You have to put your mic on. Thank you. Maybe Professor Xiaohu, you might begin while Yu Pingning is putting her mic on about adherence.
Pardon the questions. Sorry.
The question is, how can we improve the adherence of patients being treated by antidepressant treatment?
Yeah, I think for improve the first is the diagnosis. I think is very important in the practice. In China, I think it's a long road to precision medicine for psychiatry. In many hospitals, I think the diagnosis is a challenge for the residents. One day we should face about 100 outpatients. So when we diagnose it, it's a very short time. So I think when we diagnose it, it's facing a big challenge. We used about 5 or 10 minutes to give a diagnosis. I think many diagnoses is wrong. Yeah, so we give a MDD diagnosis, I said, about 30 or 40% of the MDD is other diagnosis. Comorbidity, the physical disease or other psychiatric illness. So I think the diagnosis is the first issue.
Okay.
And the other is the guidelines. The second issue is our guideline is not aligned in China. Though many Chinese psychiatrists know and learned foreign and Chinese guidelines, but in the practice, they did not do the best. So I think many factors affect that practice. The third is, I think, for many patients, psychotherapy and other non-surgical the technology is not sufficient for such TRD patients. So I think we should improve such technologies and improve the medical services.
Okay.
And I think, yeah.
Thank you. Thank you very much. Yun, you take the floor.
Can you hear me?
Yes.
I agree with Dr. Xiaohua. Just to make, first of all, we have to make a correct diagnosis. And actually, I should add on some points. That is, the patient's compliance is very important. In China, some patients don't want to eat medicine. They want to take psychotherapy. because they have some mistake on medication. They thought the medication may cause dependency, may destruct their liver function, destruct their body function. So education about the disease, about the medication is very important.
Very good. Hamish, maybe you can share some of your tricks.
I'm not sure that I have a lot more to say than what has already been said. I do think engaging with the patient, discussing what the medication is for, what it can do, what it can't do, what are the risks with it, but how those would be managed, and very much engaging them in the decision making around the various options. We're lucky that we're getting an increasing number of treatment options, and therefore we have more opportunity to be able to present options to patients, and working through those, I think, is key.
Thank you. Yun, please.
I can share two works we have done in the recent years to improve the treatment appliance for patients. The first thing is, I think public education is pretty important in China, because many of patients are public. They still have that discrimination of unipolar depression. And the second is, we using like smartphones, new apps to help patients to better connect with their doctors, and using the techniques to improve their treatment guideline, treatment compliance with the medications.
Great. There's another question then, which is a bit more technical, about comparison between TMS, VNS, and esketamine and ketamine. So Hamish, this question was mentioned for you. Do you know any comparison study?
No, not in terms of doing head-to-head comparisons at all. And they would be interesting, but I think they all have rather different places in the treatment algorithm, to be honest. I think TMS is a treatment that seems to me very appropriate early on in the treatment algorithm. Maybe when somebody has failed to respond to 1 or 2 antidepressants, you could argue the case for it to be used first line in certain situations. For example, pregnant women who maybe don't want to take medication, that might be an area where it might be useful, although more research on that is needed. But I think that's earlier on. Vagus nerve stimulation tending to be used slightly later after a number of failed treatments. And there is good evidence that if, for example, if somebody responds to ECT but doesn't remain well, that VNS could be a potentially useful treatment in that situation. So that sort of illustrates why it might be further down than TMS, which you might use before ECT. Esketamine, I think, is a really interesting one. I guess I see esketamine in a similar position to ECT in the treatment algorithm. So maybe after TMS, but maybe before VNS, but they're very, very different, esketamine and VNS. Esketamine working very rapidly and ketamine working very rapidly. But the issue is, how do we keep people well in the longer term? We know that if we give repeated treatments, we can get slightly longer periods of well-being. But how do we keep people well in the long term? Maybe we start with esketamine while VNS is starting to work, So it could be that you actually overlap these treatments, but more research is needed. But I think, for me, that's one of the really exciting areas for research is seeing whether we can actually overlap these treatments.
Thank you. Thank you very much. Very, very interesting, and definitely something we can use every day for these overlaps about the different trials and techniques, and how finding the best one for the base patient on the correct time. Yun Chen, I would be very happy if you could conclude our presentation today. For me, it was a real pleasure. I really enjoy this facing type of habits doing in our content. So it was really great. Please, Yun.
Thank you, Gowood. And I think this is my pleasure to join this symposium. And I noticed the number of participants for this session is up to 170. So, whoa, everyone likes this symposium. That's the most great news for us. And I think the grass is always greener on the other side. So that's the purpose for us to host it when East meets West. We want to exchange ideas from European, from China, and put together to see the newer methods to help our patients and their family back to normal life. So hope we can meet next year, and we will bring together more topics, hot topics between Europe and China. Thank you, Gaul, and thank all the speakers today and your great efforts to put all the things together to get into a real world. Thank you, everyone.
Thank you.
Thank you.
And see you.
A very fruitful symposium.
Thank you. Thank you. Bye-bye.